Alrighty. Hello, everybody. My name is Alexa Tinsley, and I am the Director of Programs here at Jet Foundation. I want to thank you guys for being here and helping us educate the community and learn more from Dr. Gibbons today about endocrinology. I think it's such an important topic that we don't talk about enough. So very excited to hear what she has to say today. Before we get started, I do just want to mention a few things. This webinar is being recorded, so if for any reason you have to hop off, if you know of anybody that wanted to watch but wasn't able to, please feel free to send it. Julie will send the recording once it's up on our YouTube for you all to view and share at your leisure. There is also a captions box at the bottom of your screen. It's under more, and then it has a like a CC button next to it, and you should be able to show captions and also view a full transcript as well. We will be doing a Q&A at the end, so if there are any questions, I'll be grammatically correct over here. If there are any questions, we do ask that you use the Q&A box, which again is in that more, at least for me, it's in the more box. It has a question and in a little box, question mark in a little box. We do use that primarily to review questions. This is also being streamed to Facebook, so we do try to get to questions from there. We also do monitor the chat and try to get those questions, but the guaranteed answers are going to be in that Q&A box. And if there are any questions that we don't get to, we'll definitely get those to Dr. Gibbons to see if we can get those answered for you. We know sometimes it takes time to process the information, and we always have that question afterwards, so please know that that is an option as well. Other than that, that is going to be all for me, and I will hand it off to Dr. Gibbons.
Okay, great. My name's Julie Gibbons. I'm a pediatric endocrinologist. I work at Primary Children's in Salt Lake City and just love being surrounded by the mountains. I did do my residency and fellowship in California, so I was trained at CHOC in Orange County, California, and then moved to Utah, and I've been loving it here in Utah. And I help out at the neuromuscular clinic at my children's hospital. So I see a lot of kids with Duchenne muscular dystrophy, and I also see kids for other bone disorders as well. Um, Endocrinologists are basically the hormone doctors. So a lot of people think of us as the diabetes doctors, but there's actually a lot of other hormones and hormone problems that we're involved in taking care of. Um, I'm very happy to be able to give this talk to you about all the endocrine things we think about in caring for children and teenagers with Duchenne muscular dystrophy. Um, Sorry, I couldn't think of a more creative title than endocrine care in Duchenne muscular dystrophy, but hormones are very important for keeping kids healthy and a good quality of life. Um, very excited to talk about the many different things that we do when we're seeing you in clinic for endocrine problems. Um, if you want to write down my email, if you can see it there, it's just underneath my name, but I'm sure they can also share my email with you after
Yeah,
this
we'll
talk
share
is
it in
over.
that follow-up email.
Oh, okay, perfect. And I'm good to go ahead with the presentation, right?
Yep, absolutely.
Okay. Okay, let's move along. So the endocrine domains that we think about in Duchenne muscular dystrophy are um, adrenal suppression. So the adrenal gland gets put to sleep for a little bit while you're on steroids. Delayed puberty, bone health concerns, growth concerns, and then also weight management. So there are many different things that we're thinking about when you're seeing an endocrinologist in clinic. But I wanted to start off with the adrenal gland because that's the one that I think about the most. Why hormones are affected is mostly related to the steroid medications used for Duchenne muscular dystrophy, which I'll just abbreviate as DMD, if that's all right with you guys. So the treatment does help to slow the muscle weakness. These medications are also referred to as glucocorticoids. Um, so most of the time, the kids I see are either on prednisone, deflazacort, or vamorolone, and all of these steroids can cause side effects like weight gain, adrenal suppression, delayed puberty, poor growth, and increased risk for fractures. So, like I said, starting off with the adrenal component. So, anytime you're on steroids for a long time, which is considered usually greater than 2 weeks, your adrenal gland shuts off the production of a stress hormone called cortisol. So, cortisol is extremely important for keeping you healthy and safe when you're sick. When kids are sick, it helps to bring their blood pressure up, bring their blood sugar up. So, this is a very critical hormone to have when you're sick or you're under a lot of stress. So, after about 2 weeks of being on a high dose steroid like prednisone, the adrenal gland says, oh, okay, I don't have to make cortisol on my own. I have all this cortisol floating around in my system. So, the hormones coming from the brain that talk to the adrenal gland, they start shutting off. So, the adrenal gland actually eventually shrinks a little bit and stops producing as much of its own cortisol. So this is why you should never stop prednisone once you've been on it for a long time, because your adrenal gland has kind of shrunk and isn't producing enough cortisol on its own. So this causes an increased risk for what we call adrenal crisis during severe stress or illness, and that can actually be life-threatening. This is a picture of the adrenal gland. I just wanted to show you what it looks like. So the adrenals sit on top of your kidneys on both sides, and there's many different hormones that they produce, but the main part of the adrenal gland that shrinks in chronic steroid exposure is the middle one here, the zona fasciculata, and then this one that's just outside the middle part, the reticularis. So the parts of the adrenal gland that produce cortisol, and then some mild, what we call androgens, those are the ones that are affected. Usually the part of the adrenal on the outside that helps regulate your salt balance, usually that one is able to function through a separate pathway. So you don't have to worry about that part of the adrenal gland being as affected. And then this is just showing upstream of the adrenal gland, the hypothalamus in the brain and then the anterior pituitary both interact, together to stimulate the adrenal gland to produce cortisol. So if you're on high doses of steroids for a long time, you have decreased production of the two hormones coming from the brain that tell the adrenal gland what to do. So then that's how you end up producing less cortisol when you're on steroids. So signs to look out for adrenal crisis are very severe fatigue. So I'm talking like not being able to stay awake, just like sleeping during the day when normally you'd be awake. Vomiting and stomach pain is another symptom. And then also low blood sugar and low blood pressure as well. So that's how adrenal crisis can become very severe, because you need your blood sugar to be normal, your blood pressure to be normal to recover from illness or stress. Oh, and this is a picture of a adrenal insufficiency bracelet. So I'll usually tell my patients to either wear a necklace or a bracelet that says adrenal insufficiency on it. So in case of emergencies, if there's nobody around, somebody can know that the patient has adrenal insufficiency, because there are things that we can do and medications we can use to help treat that very quickly. So you may or may not have heard of what's called stress dosing. So because the adrenal gland can't make enough cortisol to respond to illnesses, you need to give extra steroids, sometimes on top of your normal steroid dose, in order to have enough cortisol in your body. So, prednisone can be used for stress dosing, but for the kids on vamorolone or deflazacort, I also tell them to do extra stress dosing with hydrocortisone, which I'll show you in a little bit. Um, this is a picture of the Solucortef injection. I usually use what's called the Acto-vial. So the liquid is up top and the powder is in the bottom of the vial, and you just depress the top, and then the powder gets mixed with the liquid. And then you just draw it up, and you usually give it intramuscularly. If the kids are in the hospital, it can be given through the IV as well. So this medication is your emergency medication for very severe illness, or if the child is throwing up a lot and can't take their normal steroid, they should get the Solucortef, and then ideally be on their way to the emergency room, because if you're sick enough to give this injection, you're sick enough to go to the emergency room. But for the kids who are on medications for their bone health, like bisphosphonates, I have them give Solucortef prior to those medications as well, to prevent adrenal crisis. So stress dosing is usually with hydrocortisone tablets, and it's usually 3 times a day, every 8 hours. But for my kids on prednisone, I usually just tell them to double up the prednisone dose to twice a day, because that would work for stress dosing as well. However, as you can see in this table here, deflazacort and vamorolone are not used for stress dosing. So stress dosing should only be done with either hydrocortisone or prednisolone. The hydrocortisone tablets come in 5 and 10 milligram tablets. So we usually just figure out what your stress dose is and then tell you to just give that for a couple days until the illness gets better at home. And then just to talk about tapering off steroids, usually the neurologists are pretty good about getting endocrine involved if they are going to discontinue prednisone or one of the other steroids. But to avoid adrenal crisis, you really shouldn't just stop them abruptly. So usually the neurologist will taper the dose off first, and then endocrine will be involved after that point. And the Optimize DMD Foundation, they have a really good steroid tapering protocol. So that's just what I use, because they have very thorough guidelines about which dose to start the taper at. So usually once the prednisone dose gets low enough to like a moderate stress dose, then we switch over to hydrocortisone. If the patient has been on prednisone or another steroid for more than 6 months, then usually the taper is over at least a month. If it's been a shorter amount of time, a shorter taper off steroids can be done. And then usually once we're off the hydrocortisone completely, then we can recheck the adrenal glands function with usually a morning cortisol level to make sure the adrenal gland is starting to recover on its own. And moving on to the delayed puberty piece of DMD. So this is also due to steroids. Steroids are known to delay or even stop puberty from happening, which really does affect boys' growth and their mental health and confidence as well. So boys can start puberty as early as age 9. So around that time, the PCP or the neurologist should be checking for signs of puberty. And then on average, boys usually start puberty around age 11 or 12. The signs of puberty are from the production of testosterone, so a growth spurt, facial hair, hair down there, voice getting deeper, acne, body odor, and then testicular enlargement, which is what the doctor should be checking for. around age 9, they should be starting to check the private area with the patient's permission, of course. And then the guidelines for management of puberty in DMD state that testosterone replacement should be started if there's no signs by age 12 in boys who are on steroids, because of the importance of testosterone for your bone health and also growth as well. And then if the boys are not on steroids, they should have signs of puberty by age 14. So if by age 14 puberty isn't happening, then more evaluation needs to be done as to why, because it's not the steroids at that point. And then you may have an endocrinologist who is involved, and they'll have you get a bone age x-ray prior to starting treatment to help figure out what the height prediction will be. And then the bone age is usually repeated every 1 to 2 times a year, about every 6 months at the most. And we can kind of gauge how puberty is progressing at that point. So just to give you an idea of how we do the testosterone replacement, usually the starting dose is about 50 milligrams once a month. It is an intramuscular injection, so it is a little bit of a bigger needle. But some people are using sub-Q dosing, which is like a smaller needle, and that seems to work as well. I've been just doing mostly intramuscular, but the goal is to essentially put a child through a normal puberty, which normally happens over about 2 to 3 years anyway. So we just gradually increase the doses. We don't ramp them up very quickly to kind of mimic a physiologic puberty. So the ending dose is usually given either every 2 weeks or every 1 week, depending on which provider you see. Moving along to bone health concerns in DMD. So we know that steroids will weaken bones, and then just on top of that, having reduced mobility also affects the bone health and increases the risk of broken bones called fractures, and even vertebral fractures in the spine can happen without any trauma or any injury happening. So anytime a boy with DMD has back pain, we should do a spine x-ray to check for compression fractures, which are a sign of the bones being weaker. And we know from studies this happens even after just a few months of being on steroids. So we do start treatment even earlier in DMD than we do in other bone conditions, just because we know they have so many factors for having weaker bones. So it's super important to optimize the bone health because this contributes to the patient's quality of life in general. So just to give you an idea of what I look for in the bone health monitoring, I do a pretty thorough workup in the beginning to check for all the things that affect bone health. So I do just like basic electrolyte panel, calcium, phosphorus, vitamin D, thyroid. I check for celiac disease because that can affect bone health. That's where you can't eat gluten. And then I check just for like basic inflammation, and I check a parathyroid hormone level because that's the hormone that is involved in regulating your calcium levels. So normally, if you're eating a couple of servings of calcium-rich foods daily, that's enough to get your calcium requirement. But some boys who don't eat enough calcium, they take extra on top of that. And then vitamin D is found in milk that's fortified with vitamin D. But we also get it through sun exposure. So especially during the winter months when a lot of us aren't going outside and getting sun exposure, it's really important to take vitamin D in the winter time. And then I do check the level of vitamin D in the beginning and then tell patients to take it. If it's low, I'll give a higher dose, sometimes a very high dose once a week until it normalizes. And then pretty much all of the kids that I see with DMD are taking some form of vitamin D just because we know how important it is for bone health. And vitamin D is found in a lot of foods that people don't like to eat, like oily fish and foods that are kind of yucky anyways. So pretty much everybody should be on a little bit of vitamin D. Up here, this chart to the top right is the recommended doses of calcium on the left and vitamin D just to get daily. So the calcium is in milligrams per day. So you can see a teenage boy should get about 1,300 milligrams calcium per day. And then the vitamin D dose that's recommended is 600 units, but usually the capsules come in either 1,000, 2,000, or even up to 5,000. So I usually just tell patients to take either 1,000 or 2,000 units a day. And then also important for your bone health is to avoid gaining excess weight and to put pressure on the bones because that's how they become stronger. So that's why in DMD the bone health is compromised because those muscles aren't pulling on the bones normally and making them more dense, more thick. So about a year after starting steroids, I'll usually have patients get what's called a DEXA scan. That's a bone density scan. You can see in the picture up top, it's kind of looks like half of an MRI machine, but you do have to lay flat and lay still for a couple minutes during the exam. So depending on how the child's mobility is, that can be a little bit difficult for some people. So sometimes some places will get just like the femur bone density instead of the whole body if mobility is difficult. But most of the time we're able to do a whole body DEXA scan. And it's essentially just a small amount of x-rays. It's not a huge amount of radiation. It's less than you would get in a day just walking around on the earth. So there's not too much concern for radiation exposure from the DEXA scan. And also a spine x-ray should be done around 1 year after starting steroids and then usually just once a year after that. So you can see the DEXA scan printouts in the bottom right. So we are given what's called a Z-score. So a Z-score is pretty much just telling you how you compare to the average person of your age and gender and how your bone density compares. So bone density is considered to be low if the Z-score is less than -2. And we do track that over time after starting treatment to make sure that is getting better. And then the spine x-rays are done to look at the vertebra of the spine, the little bones in the spine, and to see early signs of compression fractures. So you can see the vertebra getting a little bit flatter even before the actual fracture happens. This is just a picture where I wanted to show you the different cells in the bone. So there's at the end of the bone the growth plate, and that's where new bone gets added on and causes the bones to get longer. And then your bone is constantly rebuilding itself. So there's cells called osteoblasts that are building bone, and then there's osteoclasts that are breaking down bone. So to build bone and get stronger bones, you want more building to be happening than breaking down. So the medications that we use for bone health are kind of helping to slow the bone breakdown process, and that's how they work. These medications are called bisphosphonates. So they're used in adults and kids with decreased bone mineral density, which is also called osteoporosis. So they target those cells that are breaking down bone, and they cause more bone building than breaking down. So that's how they increase the bone density. So in kids in general, if there's any vertebral compression fracture, you would meet the criteria for osteoporosis without an actual trauma causing the fracture. Or if you meet the criteria of a low DEXA scan score, Z score of less than -2, and you've had either 2 or more long bone fractures before age 10, or more than 2 long bone fractures before age 19. Oh, sorry, 3, not 2 for that last part. So for kids with DMD, we use these criteria, but we also know that they have many more risk factors for poor bone health. So we'll even start treatment earlier. So even after just the first long bone fracture, which is like a large bone, like a femur in the leg or the humerus in an arm, those are considered long bones. So it wouldn't be like a toe fracture or anything that would make us start these medications. But if there's any signs of the vertebra getting more squished looking on the spine x-ray, that would be an indication to start. Or if there's any low bone density on the DEXA scan. So I always use a medication called zoledronic acid. It's also called Zometa is the brand name. And the starting dose is lower because we do know there are some side effects, and then we just gradually ramp up the dosing until it's usually given every 6 months, which I think is very convenient because some of the other bisphosphonates you have to give them monthly, and then some of the oral medications for osteoporosis you give once a week. So I do think the every 6 months infusion is most convenient, and it works well too. We have studied this medication a lot in pediatrics, so we know it works for kids. But we do know that these medications cause low calcium levels. So usually after the first couple infusions, I actually ask patients to start taking calcium the day before the infusion and then continue calcium for about 5 days after the infusion. Because we know it's probably going to cause low calcium levels. And then I talk to patients about symptoms of low calcium like muscle tightness or cramping. And then sometimes you can have some tingling sensations around the mouth or in the fingers. These medications also lower the phosphorus levels as well. I don't see that quite as often. I do commonly see a flu-like illness after the first infusion, and we just treat with Tylenol and Motrin in that case. But then usually at the next infusions, there's no flu-like symptoms. And then really there can be allergic reactions like rashes. And in adults, sometimes you can see osteonecrosis, but that has never been reported in children. So if there has been dental work recently before starting these medications, you should talk to the dentist and get dental clearance. And then I have all my patients get the Solu-Cortef medication to prevent adrenal crisis, because we have had that happen in a few cases where a patient got their infusion and then they had low blood pressure afterwards, which indicates they probably had adrenal insufficiency. And then if there's any difficulty with the flu-like symptoms, probably the stress dosing would be recommended as well after the infusion. And if there's any history of arrhythmias, because we know calcium affects the heart, you need to have cardiology sign off on the treatment. So we know that bisphosphonates improve bone density, especially in the lumbar spine. You can see in this top graph showing a patient was started on bisphosphonates and their lumbar spine bone density went up a lot. And we do know that the vertebra can be reshaped after starting these medications. So it's very helpful for compression fractures in the spine. But there's not great evidence that these medications actually prevent fractures at all, unfortunately. But maybe in time, if we're starting boys with DMD on these medications earlier, maybe we'll see some more evidence that it helps prevent fractures. In adults, they may be trying other medications. There's a medication called teriparatide, which is a PTH analog, so it helps build bone by mimicking that hormone, parathyroid hormone. But there's really not much evidence of this in kids. We haven't really studied it, but I'm hoping there will be more medications available in the future. And then just to talk about growth in DMD. So this is also due to steroid use and just the underlying genetic condition. Um, we don't routinely use growth hormone because there are side effects from growth hormone. And then there's also concerns in DMD that the patient's quality of life actually might not be better if they're taller. So I just put in a picture of what the growth curve for growth hormone deficiency looks like. So you see it's pretty much just a flat line. So if there's ever a growth curve like this where the patient really isn't growing, that would be concerning for growth hormone deficiency. So typically the growth velocity in growth hormone deficiency declines to less than 4 centimeter per year, or the height is very low, below the third percentile. So in that case, we would consider evaluation for growth hormone deficiency at that point. But boys with DMD, they're not really at increased risk for growth hormone deficiency. It would actually be kind of odd if they did develop it. So if the growth is like that flat line that I showed you before, an endocrinologist should be involved to assess for growth hormone deficiency. So we'll usually do what's called a bone age x-ray of the hand to see if the bones are younger than the actual age. That's a sign of growth hormone deficiency. And then we do a special test called a growth hormone stimulation test in the infusion center where we put in an IV and we give 2 different medications that are supposed to stimulate the growth hormone level, and we check the growth hormone level after each medication. So it's a pretty intense test. It takes like half a day to do it, but that's the best way to check how the body is producing growth hormone. And then there are side effects of growth hormone that I always caution patients about. The one I worry most about is headaches from more pressure in the brain from growth hormone. And then sometimes there can be slipping of the hip joint and then joint pains as well. And then specifically for DMD, like I mentioned before, there's worries that growth hormone could cause more muscle weakness, because if you have taller bones, then your muscle have to stretch over a larger amount of bone, and it could be theoretically harder to function if you're taller. So, and also a lot of boys with DMD have scoliosis, and growth hormone can worsen the scoliosis as well. And then if there's any concern about the heart function, there's concerns growth hormone could worsen that, and growth hormone can also increase the blood sugar levels. So there's just a lot of things that could actually make quality of life a little bit worse from growth hormone in DMD. So, but if the patient truly has growth hormone deficiency, then I do think they would still benefit from growth hormone, because growth hormone is important for giving you energy and making you feel better just in general. But growth hormone also hasn't really been studied in DMD at all, so there's that to consider as well. However, the newest steroid vamorolone being used for DMD, it has much less of an impact on the height, which is great. So I'm really hopeful that a lot of boys will see better growth while on vamorolone. And lastly, just talking about the weight management in DMD. So as you know, steroids increase the appetite, and they also cause you to increase holding on to fluid. So this leads to weight gain. And then it's more difficult to exercise over time, which also contributes. So, in our neuromuscular clinic, we always have a dietitian meet with you every time, which is great. Um, Once the patient starts to gain weight, I check the diabetes test called an A1C at least once a year, and then check the cholesterol once a year. But when I was talking to one of the providers at CHOP in Philadelphia, he says he rarely sees boys with DMD develop type 2 diabetes. Um, but if the patient had an abnormal A1C, we could try treating with a medication called metformin. Um, and if things progressed, we could use insulin for treatment, but that doesn't happen very commonly in DMD. So just wanted to let you know the A1C that is consistent with what we call pre-diabetes is above 5.7, but less than 6.4. And then when you get to above 6.5, you cross over into what we call the diabetes range. So this should be tracked at least once a year if the boys are seeing weight gain, and then they should be referred to an endocrinologist if they have an abnormal A1C. You can prevent some of the weight gain with just lifestyle changes like diet and exercise, but obviously this is very difficult. So there's more patients that are asking about these weight loss medications like Ozempic. So Ozempic is the one you may have heard of most commonly, but there's a bunch of different ones. They're all called GLP-1 agonists. These aren't really well studied in DMD at all, but I'm sure a lot of people are starting to research them now. They do have side effects that can be pretty bad for some people, usually nausea and vomiting in the first couple weeks. And sometimes that can be so bad that the patient actually stops taking it. They don't want to take it anymore. And then it can suppress the appetite so much that they barely eat, which isn't good either. And then rarely there can be gallbladder problems. And I'm sure as we start using these medications more and more in kids, we'll discover more side effects. But for now, most of the side effects seem to go away completely if you stop the medication. The concern with using these in Duchenne muscular dystrophy is that we know they cause muscle loss, which isn't great for a condition where the muscle is affected already. So but we just haven't studied it as well, so we don't know if it really would cause more muscle weakness. But you do have to be able to eat more protein when you're on these medications to compensate for the muscle loss. And then there's also concern that if a child loses weight, it'll impact the bone health as well. So there may be some of these medications in the future that might cause less muscle loss, and that's something we're very interested in. This is just a picture showing the GLP-1 medications and how they work. So they work by slowing gastric emptying, and they also decrease your appetite by working on the pathway in the brain that's involved in appetite. I'm not sure if we completely understand the complete mechanism for that yet, but it's very interesting how these medications work. But that's why they can cause a lot of GI side effects because of the effects on the stomach. So the key takeaways, if you don't remember anything else from this very long and wordy lecture that I put together, I just want you to be able to know when you should be seeing an endocrinologist. Hopefully you are already seeing an endocrinologist if you have any of these concerns or if you're on steroids, but I like to see the kids with DMD when starting steroids so I can discuss stress dosing and the emergency dosing of the Solu-Cortef. And then if the growth velocity is not normal, I like to do a growth evaluation. If there's no sign of puberty by age 12 while the kids are on steroids, they should be considered to start testosterone at that point because that will help a lot with the bone health and the growth as well. And then if the BMI is greater than 90th percentile and lifestyle changes aren't effective, or if there's an abnormal A1C level, that would be a good time to talk to your friendly neighborhood endocrinologist. And then, of course, if there's any concern for what we call fragility fractures, where a fracture happens without an obvious trauma that would be expected to cause a bone to break. So, kids with fragility fractures will bump into a coffee table and break a bone, or just be like skipping on the front lawn and then randomly break a bone. That's what fragility fractures normally look like. Or if there's any vertebral compression fractures or any signs of changes in the vertebrae on a spine x-ray. You should also talk to your endocrinologist about starting treatment with the bisphosphonate medications. So I hope I didn't go too long, and I hope that I didn't do too much doctor speaking.
No, I've
Um,
I've had people coming in and saying, "Oh my God, I didn't even know that." Like, so solid. Thank you very much. And we have
oh, that's
quite a
great.
few questions for you.
Oh, great. Well, these are resources I like. I like the Pediatric Endocrine Society. They have a bunch of educational handouts you can find here. And then I really like what the Optimized DMD folks are doing. They have a lot of great resources. So you don't even have to be an endocrinologist to manage the steroids. They've put some great recommendations together.
And we will make sure to share those as well in that email. So thank you so much.
Yeah. All right. I'll stop sharing.
All right, I will start with the questions for you. Um, my adult son with DMD is on chronic deflazacort and recently started Duvizat, seeing a significant rise in triglycerides, which we know is a side effect of Duvizat. From an endocrine perspective, how do you recommend managing lipid elevation in adults, and should we consider specific dietary interventions to help lower the lipids or lipid lowering medications, or is it just a matter of monitoring?
Oh, yeah, great question. I don't remember what that second medication does. It's not like a steroid. It must be like a newer
So
treatment.
Duvizat is, yeah, it's an HDAC inhibitor.
Oh, okay. I haven't seen that many patients on that medication yet, but in general, if the cholesterol is high, you can start with lifestyle changes. So, meeting with a dietitian who usually tells you to like limit fats to like less than 20% of your diet and things like that. But if the cholesterol continues to be high, there are lipid lowering medications. So there's like statins if it's the total cholesterol that's high, or if it's just the triglycerides. There's omega 3 or there's fibrates. So there's different medications that can be tried. And we actually have at Primary Children's, we have a cardiologist who runs a lipid clinic, and they help us with a lot of the lipid management, which is great.
Perfect. Thank you.
Mhm.
Any suggestions to promote bone health, weight bearing? Wait, I'm just going to read it. Are there any suggestions to promote bone health when they become non-ambulatory, and does swimming help?
Yeah, unfortunately, swimming, you don't put much pressure on your bones at all. So, although it's great for like a cardio exercise to do, it's like good for your heart health. It's not the best for bone health. Um, so, just really trying to put as much weight on your body as you can. But yeah, once you become less mobile, that's pretty difficult.
Absolutely. You mentioned stress dosing with Solu-Cortef before Zometa infusions. Is this something we should be asking our endocrinologist about? It's never been recommended before. And that's actually something someone else had said to me as well.
Yeah, I don't think it's anything that people normally think about, but you should be getting a dose of the Solu-Cortef, which is the IV hydrocortisone, before the bisphosphonate infusions, because we've actually had a couple cases where patients got their medication and they had probably adrenal crisis after that. So, yeah, I would ask your endocrinologist what they think about giving the Solu-Cortef like about a half hour before the bisphosphonate is given.
Thank you. On bisphosphonates, the caution for dental work was mentioned. What about surgeries like spinal fusions for scoliosis? Are there any precautions that should be taken?
Not for spinal fusion. Sometimes the orthopedists like to take a break from bisphosphonates for a couple months after a hip surgery, but not all of them do that. So I would just ask your orthopedic doctor. But the spinal fusion, there shouldn't be any problem with that.
Awesome. Do you have any suggestions for those who are unable to lie flat in the DEXA scan, particularly for our older guys and girls?
Yeah, it's so difficult to lie flat for a lot of like the teenagers I see. So sometimes I just don't have them get a DEXA scan and we just continue the treatment because we know that we're going to be continuing the bisphosphonate treatment pretty much indefinitely, right? But some places, like when I was talking to one of the doctors in Philadelphia, they were saying they sometimes get a forearm or a leg x ray. I mean, DEXA, not x ray, if mobility is a problem.
Do you feel like that gives a enough of a glimpse
It's
into
not as good. It's not as good as the whole body, but it's better than nothing. And the doctor I was talking to in Philadelphia, he said that he's looking more at like the rate of the bone loss rather than like the actual Z score. So it can at least show us like which direction the bone density is heading in.
perfect? And then what has your experience been with Forteo injections, if any, in the older population?
I have not used it yet, but I think it's mostly in adults at this point. But I'm hoping it'll work its way down to kids eventually.
Yeah,
But right now, bisphosphonates like the zoledronic acid, they're still the first line treatment.
got it. If anyone has any other questions, I'm going to give it a minute. I'm actually going to check Facebook and see if there's anything on there. But thank you again, Dr. Gibbons. We truly appreciate you making time. I do think that this is so very important. So thank you for taking time out of your day and your week to make sure that we're helping to educate the community and allowing them to make informed decisions about care. If anybody does have any questions, Dr. Gibbons did share her email. We will make sure to share that along with the resources that she provided with the recording once it's up on YouTube. And again, thank you all for being here and watching this webinar today. And we hope to see you guys again soon. And then again, thank you, Dr. Gibbons. We truly appreciate you.
Thanks. I hope it was helpful and
It
hope you
was,
all
it really
feel
was.
more informed.
Yes, thank you so much and have a wonderful day, everybody.